Good evening, everyone, and welcome to today's special webinar on IVF with donor eggs. My name is Shifa, and I'm one of the patient care coordinators at London Egg Bank, and it's my pleasure to be hosting this informative session with you all today. We are incredibly fortunate to have a distinguished expert with us today, Dr. Vendola, who is a renowned consultant gynecologist and specialist in reproductive medicine. Dr. Vendola has extensive experience in IVF with donor eggs, and today she will be sharing her insights on the process, the latest advancement in the field, and emotional and physical considerations involved in both the donor and recipient journeys. Before we dive into today's session, I encourage you all to keep your questions ready as we will have a dedicated Q&A session towards the end. Without further delay, Dr. Vendola, over to you.
Thank you so much, Shifa, and thanks everyone to be here later today. Nice to meet you. I'm Dr. Vendola. I'm working with the London Egg Bank and the London Women Clinic for the last 10 years. So we started our experience long ago, but London Women Clinic far much longer, over 30 years of experience. Now, we do this quite a lot. And this is why the London Egg Bank then is born as such, because we do have an extent expertise from the embryology team on how to freeze and thaw eggs. And the reason why we approach to donor eggs, of course, are different. It can be because as women, we decided to start, our journey later on in our life for many reasons. It can be instead that sometimes we are forced as women that have problems in the very early age, as a premature ovarian insufficiency or failed treatment, reduced ovarian reserve, pathologies that have unfortunately impaired to use our own eggs, and therefore we need to start this journey quite early, in the sometimes early 30s. Sometimes it is a matter of choice of life. We have same-sex couples or failures. This is not just an emotional journey. This is a financial journey as well. And therefore, despite we want to try as much as we can with our own resource, our own eggs, then at one point we need to put everything on a scale and consider what will give her a higher chance to succeed in the final goal, which is having a baby. So this is why I'm saying sometimes we take this decision based on failing cycle, not because it's impossible to reach that goal, but the likelihood with your own egg, it might be definitely lower compared than to the one of using donor eggs. So this is another, again, way to look at it, and another reason why some couples decide to pursue this route. What is the process? So how does it work? Some women come that, again, already have done fertility treatment with their own eggs, so they come with a quite of a background of treatments, so they come prepared. But some other women approach this journey for the first time because, as I said, sometimes it's because it's a late decision in life. The idea is that we're not going to use your own eggs. We're going to use donor eggs, and they will be fertilized with your partner if you have, or if you don't have a partner, they will be fertilized with a donor sperm. The donor can be sperm can be known or unknown. That is your choice. We do work also with the London Sperm Bank, but there are other banks. So there are different ways to do things. Of course, that is an aspect. So the first aspect is creating embryos, and then the other aspect is creating embryos to be transferred into you. This is a journey on its own. Even if you come from fertility treatment with your own eggs and you think, well, now I'm adding, donor eggs and that would be successful. True, the majority of cases we are, and even straight away we'll talk about statistic. But this is a journey, so it's a combination of factors. It's the egg and the sperm that will have to create a good embryo, and then is the environment that need to be the right environment for the embryo to be taken. The wrong environment won't take the right embryo, and the wrong embryo won't be taken from the right environment. So it's the combination of the right environment and the right embryo that will make the pregnancy. So this is why this is a journey. Now, I appreciate, as I said before, a lot of the time we want to try to do things with our own resource, which means our own eggs, because we think that that is a sense of belonging. So there are, again, not just financial, but psychological aspects. A lot of psychological aspects involved in the treatment. And this is why sometimes you delay your choice, because you think that you want to use your own resource. Well, what I can reassure you is that, yes, probably if you're talking about the genetic descendant of the genes, they won't belong from you, they won't come from you, they won't belong to you. But what the genes are activated or deactivated, which it means, and they will dictate the health of your baby, that will be up to you. So is your baby more than ever? This is the value of the epigenetic. This is the value of carrying a baby yourself for 9 months and dictating essentially the health of it, because the environment, especially in that 9 months, dictate all the activation and deactivation of the genes that will make your baby. So the same baby in another womb would be different. It will have different health conditions. So this is very important, also because this would be transmitted in generations. So there is a lot that your baby will have from you, and a lot that you will actually influence the baby for future. So your baby more than ever. Now the journey started in a way that we like to work all together as different part. We do have, of course, the clinical staff and that consult your history, your everything that is, of course, in couples or for single women. They will go through all your medical history, your condition. They will, first of all, put you at best, because we want to get you pregnant nor sick. And sometimes, especially when we approach later in age, there are things that need to be confirmed as, as all fine, and give it give it a go to go ahead, especially in a later age. So definitely there has to be, a component of the doctors that need to work in this respect to put you at best. Then there will be a matching team. So you see, we will see now all the structure of the team. There will be a matching team, and the matching team will help you with the matching of your choice of the donors. We do work mostly with frozen eggs, but we do have also fresh eggs. We do have then another part that is done with a counselor, and the counseling session is quite an informative chat, because you need to be aware about the regulation behind. And again, the emotional aspect and the aspect related to the HFEA, we'll go through that as well. And then there would be the nurse team, so all the team all together, and your coordinator is the person that's going to put all of us together, and the person you refer to. Okay, so it's a team work. What happened is that essentially, as I was saying before, we're going to work on one side on creating embryos, and you will work with the lab team in that. As I said, they're very, very expert in that. And then on the other side, we will work with yourself, and we will try to put your best. We need to prepare you. Of course, if you are in a fertile age that you still have your menstrual cycle, there are different ways to do things. Sometimes we work in a natural cycle, or sometimes we need to induce the cycles, because you might be in menopause already. So if you are in menopause, this is still possible, but we need to work on it. So this is what I was saying in the beginning. We need to put you, in the right place. And then at the same time, again, we will work in the embryology side to create embryos. Typically, the process, again, can be done in two ways. We can have a sort of throwing the eggs, fertilizing, and transfer it. We will synchronize your menstrual period, or with a pill if you don't have it, or HRT. We'll need to, as I said, customize. And then we will do the transfer straight away, synchronizing the 5 days blastocyst that we work with, or otherwise sometimes we work in a freeze-all cycle. So then we start and we create embryos, we freeze the embryos, and then literally normally the following month we proceed with the preparation. We give you medicine, which normally are estrogens and progesterone, and approximately after 16 days pretty much we go ahead with the transfer. In terms of outcomes, normally we do have a live birth rate per embryo transfer around 45-50%. Of course, it depends. It's pretty much stratified per age, but of course it depends if there are no other health conditions behind. But the pregnancy rate actually increases for cumulative rates, which means when we have more attempts. We do know that if we get more attempts, we can get more successful. And this is what I was saying before. It is a journey. Now, normally the minimum batch is 6 eggs, and out of 6 eggs, you need to consider that pretty much between 90-92% survive the towing. We have a fertilization rate which is around 70-75%, which is a very good KPI for the lab. And then we do have a conversion blastulation rate between 40-60%, of course, dependent also on the male side, which 40-65%, again, more in accordance with the sperm factor, which means that out of a batch of 6 eggs, normally you ended up between 1 and 2 blastocysts, but there are also bigger batches like the 10-1. We mostly work with frozen eggs. First, because they are all already screened, they are all in display. You can work with your matching team to decide, how many eggs you want, and all the questions about, whatever you want to know about the donor, really. So this is quite, I can't say too quick because there is a timing of admin that normally is a couple of months minimum before we start. Not because we don't have the donor is there, and again you can match it, choose it, but there are admin and admin side, because we have to sign all the consent. You need to sign the consent. We need to upload everything from the embryologist and the HFA. So this take a couple of months anyway. So we do work though with frozen eggs a lot, because normally the catalog is bigger, and again it's easy access. But we do have the possibility to work with fresh eggs. Of course, the catalog, it can't be the same. This is talking about fresh eggs. So it means the donor that coming through the door, but it's not a particularly longer wait, not necessarily, because as I said, there is this cushion of a couple of months that you really need to have it anyway. So from when you start, you can even choose fresh eggs, and this pretty much the same time, I would say. But in terms of timing, then Shifa will cover better. As a clinician, we might be a little bit generous, and then they very strict. So the part that we want to inform you, especially in the counseling session, which is, as I said, is a very important part, because it is a psychological journey. We need to be on the same page. You as a couple, if you are a couple, or if you are on your own, you need to be on the same page. You need to know that the donor the child is entitled to know the donor at the age of 18 through HFEA. So that is important for you to have this conversation to your child, and the way you will talk to your child later on. It is a regulation that actually is relatively new, and it has been done in the interest, of course, of the child. And the reason is because we could see really the difference of the fact that when the child was informed about the fact that he was born from donor eggs, he wasn't like a shock, or it wasn't an information that it was seen as disruption. He could contact the donor, and this made the process far much easier to be accepted, compared with the fact that when you do have an adoption, which is quite really difficult, because you sort of don't know that aspect, and psychologically is like a barrier. So it is more a struggle. Instead, we this is not a problem. The donors are fine if you contact them. If you don't, they're really easy on that. There are no legal rights from their side. It's all well regulated. So it's a peace of mind for everybody. So this is why JFA has reached the conclusion in 2005 to change this as a child to be informed. Then, of course, again, this is pretty much what I just explained to you before. This is part of, the reason why we choose and you choose to go through the journey using donor eggs rather than adoption, I suppose. And there is a big difference in many aspects, as the one that I mentioned before. Now, of course, you want to know about the donors, who are they, and this is why the matching team is a dedicated team to answer your question. The bracket of age, it goes from the 20s to the 35, and that is pretty much everything that includes the peak of the fertility of a woman. And we like to, and we are actually very proud of the fact that we include really a very good variety of all ethnicities, because in a lot of other banks they are quite limited. Instead, probably because this is London based, this is definitely an advantage in this respect. We are very proud of the fact that we have a multicultural background, so this helps us a lot. And of course, all the donors are screened, all the donors are checked. There are triple checked because they go through all the assessment at the beginning about the medical history, about the medical condition. We do ask genetic information. We do test for genetic disease. We have a geneticist that goes through all the cases before accepting them. And they are all screened for infections. There's a lot behind. There's a lot of work behind. So this is why when you choose your donor, you can be confident that is a good choice. And sometimes you say, but why is it a decision that they do it because they want money out of it? We are not in US. So in US, it is basically it is basically financially motivated, but this is not the case in UK. So in UK, they want to help others. The first interest when they go through the egg collection, or when they go through the simulation, is it fine? Is it going to work? How many eggs have we got, and how many people can we help? So it is really for helping purpose. They come from, as I said, very different background, and the majority of them have experienced themselves in their family struggling, and so they know how difficult it is, and therefore they want to help. They have a compensation. They don't get money, as I said, as in UA. It's a compensation. So this is why they take all the troubles to go to all the stimulation and everything, because they want to help. And we are very grateful. So what the screening they undergo, as I was saying before, there are all sorts of screening, genetic screening, blood test, infection, disease. Of course, they need to pass the fact that they have a good ovarian reserve, good antifollicular count, so test, ultrasound, consultation, counseling. They have to pass quite a lot before they get accepted, I have to say. So this also tells you about the motivation that they have. And I think that here I will ask Shifa to probably get a little bit more in details with you about the other admin aspect of the process, and then I will take all your clinical questions afterwards.
Thank you, Dr. Vendola. Before we move on with the presentation, I would like to remind everyone to put down their questions in the chat box. I can see that there are some, but it would be good if we can have more so that we can discuss them all together in the end during our Q&A session. Moving on to how the database works, if you go on our website, you would be able to see a database, a screenshot of which is on the slide at the moment. So this is how our donor database looks like. On the left-hand side, you can see that there are some filters that you can use to create shortlists as per your preference for donors. It is a live system, so it is possible that the donors that you're looking at right now may not be available later on when you are actually ready to purchase them. But we do have regular updates for the database. We try to add as many donors and as soon as possible, so you would have good options to choose from. Dr. Vendola, next slide, please. So at the moment, you can register on the website, but you'll have limited access to the website. But once you have your doctor's consultation with one of our doctors and your treatment plan is in place, we will give you full access to our website. And this is how the website looks like once you have full access. So you will be able to have access to full profile of the donors. So you'd be able to see their interests and hobbies, their skills, any additional information if it is available. You'd also be able to see medical information about them. So when we are recruiting our donors, we do certain tests for them. So a list of those tests is available for each donor's profile, and also some additional medical information, such as if the donor is found to be a carrier of any condition that we test them for. Also, you'd be able to see things such as their hair color, eye color, their nationality, ethnicity, their qualification, and their occupation. Next slide, please, Dr. Vendola. With full access, you'll also have access to their extended profiles. It is a very interesting document, and it is very interesting to read their messages as well. We have added some example of those on the slides for you to see how our donors and what message they want to pass on to their baby born from their donation and to yourselves as well. So in the extended profiles, it is a document of about 10 questions that they answer at the time of their donation, which will give you better insight into their personality, because it will have questions such as what was their favorite subject in school, what is their dream holiday destination, what is their motivation, and some goodwill messages as well. At London Egg Bank, we offer different kind of packages, which are basically in two types. So one is the single cycle package, and then we do some refund packages as well. Once you have full access to the website, you'll be able to see how many eggs are available for each donor. If you're going for the single cycle package, then you can purchase eggs from the website and pay a treatment fee, which will include one embryo transfer. But with the refund packages, we offer two kinds. So there is a gold package and then there's a silver package. With silver package, you get a 50% refund if you don't have a live birth. And with the gold package, you get a 100% refund if you don't have a baby. The cost for these packages are on our website. However, it is important to note that these packages are subject to medical review. So if you are interested in these packages, we can arrange a consultation with our doctors to review your medical history, and they would be able to advise you on your eligibility. But if you are eligible, we have a curated list of donors for these particular packages from whom we have had outcomes before at our clinic. So we will be able to match you with these donors, and you can do 2 cycles with up to 12 eggs allocated to you in 2 different cycles. Now coming to why London Egg Bank. Firstly, because we are proudly the largest bank of donor eggs in the UK, and we have a variety for you if you prefer fresh or frozen, and there are no waiting times to start treatment with us. It completely depends on how quickly you can select your donor. We also have leading success rates for IVF with donor eggs, and we have teams of dedicated egg donation experts. And third, and the most important one, because we all know how difficult IVF treatment journeys could be, and it is very unpredictable. So we do have embryo guarantees for all treatment plans to support you in your journey. Your next steps. So if you would like to start your journey with us, then your first step would be to book in an initial consultation with one of our fertility specialists, followed by a consultation with our matching coordinator. That person would be a dedicated coordinator for yourself who you can share your preferences with, what you're looking for in your donor, and that person can look into a database and can create shortlist for you. And they can also do photo matching. So if are looking for someone who looks similar to yourself, then you can send us your photos and our matching coordinator can compare your photo with the donor's photo and they can advise on some good matches for you. Second would be to have a session with one of our counselor. This is highly recommended so that you get a chance to understand how comfortable you are using donor eggs, what to expect from treatment emotionally as well, or if you have any concerns. Third is when you are ready to begin treatment, we will create a checklist as well for you to complete before you can actually start treatment. So it will have some consent forms to complete, it will have some blood tests to take, and also to select your donor and order your eggs through our website. And fourth is once everything is completed, we will arrange a nurse consultation for you to discuss your treatment plan and arrange medication. And from there, you can start your treatment. As a thank you for attending today, we would be very pleased to offer you reduced fee initial consultation packages, the details of which are on the slide. You will also receive an email tomorrow with this offer. So if you would like to proceed and book consultation or the investigations with us, feel free to respond to the email. If you have any questions as well, we would be happy to arrange a call with you.
Thank you, Shifa.
Thank you. I believe that's the end of our presentation. Dr. Vendola, we do have some questions. So I'm going to start with the first one, and that is, if you buy 6 eggs, how many will survive and fertilize to create a baby?
I did cover this quickly before. So essentially, remember that approximately 92% of the eggs survive the towing. Out of that, approximately after 1 day, you will see the fertilization, and 75% will be fertilized. And then we normally work in the stage of the blastocyst, which means where the cells reproduce themselves up to 100, 150 after 5 days. Sometimes it can take a little bit longer, 6 days. And out of that, so the embryo wait an extra day, out of that between 40 and 60%. This is why I was saying out of a batch of 6, you might end up between 1 and 2 embryos. Normally out of a batch of 10, it can be between 2 and 4 embryos. That is on average, but of course, it is very much dependent on the sperm factor. Remember that when we have a sperm factor, the situation can be different. Yes, we do ICSI in the majority of cases, even because the eggs, especially the frozen one, are stripped, so we have to do ICSI. But if the semen has a higher quality, has a better characteristic, then we can get a little bit higher number of embryo that we can create. If the sperm has a poor quality, of course, we can still create embryos, but we probably won't create 4 embryos. So that has an impact, and also that has an impact on your choice. So on how many you should get. Of course, as I said, as Shifa said, that the consultation will be there to help you and guide you. Then is every time is a emotional, but it's also a financial decision. So you need to then put the information that we will discuss from a clinical point of view into your possibility and your choice.
Thank you, Dr. Vendola. The second question is, are all eggs from UK residents or do some come from other countries? I think I can answer this one. We are a HFEA licensed clinic. So we recruit all of our donors in line with HFEA regulations, and which means that they are all UK residents. They could be from different ethnicities because as UK is a hub for students, so there could be students coming in who are looking to donate. So it could be different ethnicities, but they are UK residents. Thank you. The next one is, are patient able to see the 3-generation medical history for donors? Sorry, go ahead.
to be honest. So you can ask all the information, absolutely. That's not a problem. Everything we know, we will tell you. That is fine. If you are asking us, normally HFEA don't provide all the information. That's not something that HFEA would do. If you ask us, of course, as I said, whatever we know, we will let you know about the information. About all the generation, normally we go through grandparents, of course. But normally you don't get the full information on, this is not something that HFEA has requested. So we do it because we, of course, as I said, we do a lot of screening, a lot of information, but it's not something that is actually requested. Okay, so you will get if you want to know.
The next question is, we have shortlisted a donor on the database, but are waiting for third-part agreement to use eggs at another clinic. How long does this normally take? Well, Dr. Vendola, I can answer this one. So for the third-party agreements, it completely depends on your clinic, how soon they can sign the agreement, because it's just about having a conversation with us. We discuss everything with them. If they have any questions, we get back to them about it and send them the third-party agreement. It is usually a quick process, but if you're looking for a specific clinic that we don't have an agreement with, please do contact us and we can look into this for you. The next question is, can you please remind me, do the people who get access to the full database, can they only have access for 3 months to the full database and need to pay again if we have not bought the eggs yet? Can I just confirm that is correct, please? Thank you for your question. So I believe this is coming for external patient. So if you are an external patient, then there is a certain timeline in which you would need to purchase the eggs. If not, then there will be another charge to extend the period. But if you're having treatment with us, you don't have a deadline to purchase eggs within 3 months. But once you've purchased the eggs, you have a deadline to use the eggs within 4 months of purchasing them in your treatment.
Yeah, this is sometimes they get this question, they get confused about the time, but for us it's just from when you purchase it to when then you start, is this 4 months. It's not that we want to push to start. The problem is that in the past we have experience of having donors on hold for so long, and this is also not fair on the donors and on others. So this is why we put the criteria of 4 months. Of course, if something happens, we'll go through and we customize, but that is a time frame, yeah.
The next question is, are fermentation foods with live cultures good to eat during early pregnancy to improve epigenetic marks on healthy gene activation?
So you need to consider that in terms of the epigenetics, we don't literally do anything. Okay, we don't do anything. We believe that in the epigenetic, this is something that happens in you. We don't activate intentionally any genes. We don't put anything. We don't prepare the lining in a different way or the womb in a different way. So that there's nothing in this respect. Okay. So let's be clear, there's any manipulation or anything that we would add, okay?
The next question is, I live in another country in Europe. Do you do cooperation with other IVF clinics? So we are not able to transport the eggs on its own to any international clinics, but we can create embryos for you at London Egg Bank, and you can then transport the embryos to your clinic. However, we do recommend that you check with them first if they are happy to receive embryos from our clinic. Dr. Vendola, did you want to add something to this?
No, I think, no, that's fine, yeah.
The next one is, does the silver and gold package offer eggs that have been successful before? What about the normal package only offer eggs donors that haven't been successful before?
Well, you can cover by the package, then I will add
Yeah.
something probably.
So for the silver and gold package, it is not necessarily a successful donor. It just means that we have used the donor at our clinic before and her eggs have performed well, or we do have outcomes from that donor. For the normal packages, we do offer donors that may have come for their first cycle. Majority of our donors only donate once, but there are some who can do 2 or 3 cycles of donation. So these repeat donors, if they've had outcomes before, then we offer them on the silver and gold package.
So it is, of course, very reassuring to know the fact that a donor has donated and it has created embryos and it's been successful. But as I said, the pregnancy itself is a combination of factors. And again, it depends where it implants and how it implants. You know, a lot has to do with the recipient, with yourself. So there are cases that the same donor has donated to a family and he hasn't produced a baby, a live birth, and another one it has. So even if the donor has come through the door for the first time, this doesn't make it any less again successful that somebody that has donated and has produced a pregnancy. I know, as I said, of course, we we want to all have some reassurance, and that is something we look for and we appreciate it. This is why we put this this factor in the packages that is called the gold and silver. But in reality, in the normal package, there are donors that can do extremely well, unbelievably well. And this is the first time they come. So please don't be really put off from that. As I said, we need to customize, we need to make it work for you. That is what is really going to make a difference, not the fact that one, what donor has donated already and has produced a pregnancy. It is very reassuring. I appreciate that. But it's an add-on. It's not the reason for why you want to go for that. Okay, it's something, is an add-on.
Thank you, Dr. Vendola. With regards to the mentioning of epigenetic markers
Yeah.
being a responsibility of the mother during pregnancy, what are the best food to eat or drink to improve the overall health of your child?
So if you consider, as I said, the epigenetic is very important because, but it's natural, as I said, let's be absolutely clear, okay? So this is nothing that we add, or no manipulation that we add to it. So the fact that the embryo develop in your body, it means that your gene can, as I said, or a group of genes, it's not just one, it's multiple also, that can activate or deactivate the healthiness of your baby, which means that if you are diabetic for any reason, this could increase the chance of your baby of being diabetic. This could activate a gene. So the fact that you try to be as healthy as possible, this will give it the best option. And the fact that sometimes you do have some other issue with, it's not up to you, it can be the high blood pressure, it can be anything. Or it can be some genetic condition that affect the coagulation, a lot of things can be. And even that can activate or deactivate the baby gene. So in this respect, but there's nothing we can do about it. This is why it's gonna be your baby in particular. And if it was implanted in another uterus, it would be a different baby. So yes, try to stay fit and healthy, because this will be passed to your baby and to the generations. So I would say that is tremendously important. And then also is very important because it also a consideration, if how old are you when you come in through the door and starting fertility treatment? Are you, again, early in your 30s because the ovarian reserve is reduced? Are you approaching your 50? Again, that has an impact. So it's very important that you keep yourself healthy as much as possible.
Thank you. The next question is for you, Dr. Vendola. Do you offer any specific treatments for thin endometrium, such as endometrial PRP?
So we don't do, but so there are some treatments that are recognized, and now probably if you have done fertility treatment, the HFEA has all the set of lighting, the green, the red, the yellow, the black. So unfortunately, there are things that other clinic decided to use more on a probably they customize in this way if we want, or sometimes they use it empirically. But as a clinic, as a choice, our medical director is a renowned scientist, and we do not believe in empirical treatment or things that have not been proven to be helpful and successful for the majority of patients, which means that they get between the green and the yellow lighting. So if it is something that has not been proven to work, then unfortunately we don't do it. And PRP is one of this. We do what we do instead for lining that is thin. We do have a session of our clinic that go through the biopsy. So we biopsy the endometrium. We try to understand what's the level of the inflammatory cells, what the level of the immunocompetence of your endometrium, and then we try to understand what is the best and adding treatment in accordance with that. But you need to consider that one of the tools that we thought it was a very good tool until a few years ago, that it was the endometrial receptivity and how it was receptive, and the testing, the ERA test, and so on. Then they have been proven, they have been abandoned. We used to do it until 3 years ago. Now we don't do it anymore. In Spain as well, they were pioneers of this, and now it has gone lower and lower because we know that every time that the endometrium menstruates, and then it recreates a different habits inside, and it is very difficult because it's a combination of the inflammatory cells that we can't eliminate completely, but they have to be there. And on the other time, if the endometrium is affected from a structural way and it doesn't thicken because there is a structural problem like Asherman syndrome or adhesion or something, that is really a barrier to the expansion of the uterus for the pregnancy. So as I said, we do work normally in alignment with the HFE regulation and what has been recognized as known that is helpful and successful. If it's something like infralipid or this sort of treatments, they might work for some selected cases, but it's not proven to be working, then we don't do it, including an endo scratching. Of course, we do it sometimes, but that's definitely not a routine for us because it has not proven that it has benefit for everyone. Okay.
Thank you, Dr. Vendola. The next question is PGT testing with donor eggs, yes or no?
So it's a very good question, and that has to be put in the context, I think, of our context. Let's put it this way. So the reason why we PG test the embryo is because we think that there is a likelihood of finding a chromosomal abnormalities. And the fact that there is a chromosomal abnormalities put the embryo in a situation that it likely will not implant, or if it will implant, it will miscarry. Okay, so this is why we want to PG test the embryo. And when does it happen? When do you have chromosomal abnormalities? Normally, when you have infertility treatment with your own eggs, in the later 30s, beginning 40s, or over 40. That is the high likelihood. When we have the bracket of the age below the 35, which is what we have with donors, it's fair to say that the likelihood of chromosomal abnormalities is around the 20%. Is not zero. Of course, even somebody that comes at 20 years old can have the possibility to have an unemployed embryo, so an embryo that is chromosomically abnormal. But is low. So consider that an average of embryos we create is between 2 and 3. And if that is what we create, you need to say to yourself, if I have 2 or 3 attempts, do I want to test the embryos? And then, of course, testing is an cost. When you test the embryo, is a biopsy. We do it quite safely, quite widely. but it's still a biopsy. It can come with no results, unfortunately, sometimes, and you need to test the embryo again if you want to have a result. It comes with the fact that in some cases the results are not euploid, aneuploid, but you might have mosaic. So there again, we have a genetist to have the conversation if that is an embryo that you would transfer or not. So all these things, again, if a PGTA was the clean cut between having, you know, a successful embryos to transfer or not, probably I would say yes, and I do say yes in general. But when you do fertility treatment in our context, this is what I was trying to say. In our context, with a limited number of embryos we create, with the low likelihood of creating abnormal embryos, then I would say on a general case, we don't PG test the embryo. But I want to say a but. If you come that you have done, which I see, honestly, I do see that, you done fertility treatment with your own eggs and you have done 11, 12 embryo transfer. Then I think you want to move to something that is going to give you at least 65% chance of transferring the embryo with a live birth, which is again a PG tested embryo. And in that case, probably if you approach us that late, maybe we can consider that. If we do that, which again we do at times, because I do have this patient as well, then we need to work in a larger batch to create a larger number of embryos. So we might create 6 embryos, which again, it's probably more likely to be worth it to test it, because you're not going to do other 6 embryo transfer, and that is, you know, a different condition. Or we do it when we know that there is a male transmitted condition, then we have to PG test the embryo to check that this is excluded. Balance translocations, you know, there are other exceptions. So this is when I would say yes to the PG testing.
Thank you, Dr. Vendola. The next question is, would you recommend a donor who is resident in UK rather than abroad, even if both egg banks are regulated by HFEA?
So, as Shifa said, it's to be honest, I don't think it changes much if the patient is moving in other countries or not. This is London. It's very likely that they might come here, be resident for some times, and then maybe move somewhere else. That can definitely happen. It happened in a lot of the case, but I wouldn't choose one rather than the other one. I don't think it makes a difference if we are talking about, of course, frozen eggs, because they are then they donated. It's fine. If you're talking about fresh eggs, well, that is different. Probably, I would say, get somebody that is stable where it is. But otherwise, I don't see a problem in that.
The next question is, am I right in thinking all eggs in the egg bank are frozen? Are fresh eggs available? And if so, how would we access them?
Yeah, they are available. As I said at the very beginning, this is one option that we have. It is different because, as I said, the more popular catalog is the frozen catalog because it is a catalog on itself. So as Shifa was explaining, you can access the catalog, have a look, have a dedicated matching team that will actually match with that. So with the fresh, we do have a dedicated team that works with the fresh. Of course, the terms and conditions are different. And of course, we can't have a complete catalog because it depends on the donor that comes through the door on that month or in the following couple of months. So it does work that has to be more customized. So you need to work with your fresh matching team to see which are the donors available in the following couple of months. And then again, you cover with the coordinator which are the terms and conditions, because of course it is a fresh donation. It can be that the donor, again, we can collect the number of eggs we're supposed to collect, and they can be less, they can be more, and it can be that the donation it doesn't go through because that month she can't do it, so we need to likely postpone another month. So there are variables in the fresh donation. This is why I was saying normally is more popular the frozen, but there are absolutely, that is a possibility. 100%. And please, Shifa, go from your admin side if you want to clarify about the terms and conditions with us.
So with fresh eggs, definitely we cannot have a catalog, as Dr. Vendola mentioned, because it will depend on the donor availability at that time. But once you've had your doctor's consultation, we will put you in contact with our matching team who manages the fresh program. You can give her your preferences and they will keep an eye out on all the donors that could be of your interest or could match your preferences. And they will offer them to you as and when the donors come in. And then you'll have a choice to choose which donor you'd like to proceed with. The next question, Dr. Vendola, is when it comes to choosing a donor, would donor genetics, that is carrier of genes or not, be more important than physical matching characteristics with recipients?
So it is important. This is what we tested, of course. But the reason that is important is because she is a carrier, which means she's not affected. Okay, she has one of the gene out of the two. So the reason why we test them is because if it comes that the donor is the carrier, we can test your partner. That is the main reason why we do it. Because again, they are not affected, they are fine, even if they are carrier. So the reason why we do it is because the problem would be if your partner is affected from the same condition, because that will give the offspring the possibility 1 out of 4 to be affected. That's the thing that we want to avoid. The fact that if you choose a donor that is a carrier and your partner is not, then the baby will have 50% of not having absolutely anything and 50% of being a carrier, which it means still not having the condition, not being affected. So normally it's not a problem. As I said, it is the reason why we do it, and the reason why it's important to know is because we need to test the partner, your partner.
Thank you. The next question is, if we do treatment with you, is it done at a specific clinic location or any London Women's Clinic location? So for treatment, we have 3 centers where our lab and theaters are based. One is in Darlington, the other one is in Cardiff, and the third one is London Harley Street. But we've also recently opened up Bromley. So you can have your treatments such as embryo creation as well as your theater appointments done at these clinics. But other clinics can be used for appointments such as blood tests, scans, semen analysis, or to see doctors as well.
And there are a lot of satellites that can be
Yeah.
used also as that. They are not just this. These are the main one for consultation, but for blood, for everything else, for scans, we do have quite bright, and we have quite a few. There is the bridge, so quite a few possibilities. But in London, the theaters are based only in Harley Street in London.
Are we told how long the eggs are or have been in frozen storage for? So unfortunately, we are not able to give out that information about how long the eggs have been in storage. But from a clinical perspective, Dr. Vendola, does that matter?
So what you need to consider is that I appreciate the freezing. The word freezing might create the idea that if it's frozen for too long, it might not be good. But freezing is a misleading word. The word that we should use is vitrified. Okay, so the eggs and the embryos, when they get the embryos, are vitrified, which it means they are exactly in the state when you thaw them, when you put them. Okay, so it doesn't matter if they are there for 5 days, or if they're there for 10 days, or if they're there for 1 year, or if they're there for 22 years. Now, we're not that long, so and actually it has been extended now the freezing to 55 years, so quite relatively recent. So I don't think that this is a problem or concern for now.
Perfect, thank you. The next question is, in your embryo guarantee programs, what do you mean by a viable embryo guaranteed? What conditions need to have that viable embryos? What if we do PGTA what results would be considered as viable?
So, well, I don't know if you want to discuss the terms and conditions, and then I'll talk about the
Yeah.
embryo. Mm.
So, in terms of the terms and conditions, we guarantee a transferable embryo. That means that any embryo that we would expect to result into a pregnancy, definitely we do grade the embryos, so which I think Dr. Vendola will mention. But you will have a chance to discuss this with your consultant as well as the lab team on what embryos are created, what their grades are, if they are freezable or if they are transferable.
So what it really means is that an embryo that has a chance, okay? An embryo that has a chance, because sometimes, as I said before, for example, the blastocysts can be formed in a day that is day 6, okay, rather than day 5. Now, embryo that are day 6, it's not that they don't produce a live birth. Actually, they do quite well. Sometimes we do transfer day 5, they don't produce a pregnancy, and day 6 they do. It's just that they've done it a little bit later. So this create probably between 5 and 10% less sometimes chance. But it's still a viable embryo to do it, to implant. And that's what we consider. So it's just a way to say that we come say that we guarantee every time to create embryo graded for AA, because this will be unrealistic. And so that is more in this respect, okay? So to make sure that is an embryo that it has the opportunity and the possibility to be transferred and be successful.
Perfect. The next question is, are the donors for frozen eggs notified when they are chosen? So definitely the donor does not have any information about the recipients or about their donation as well. It's just that they do have an option to contact us after 1 year of their donation to see if their donation has been successful. If the donor contacts us, we are able to tell them if there has been a live birth. And if there has been, then we are able to tell them the sex and year of birth of any children born from their donation, but they won't be notified when you choose their eggs.
You need to consider that some, it's a different. They do it in a different ways. Sometimes they do want to know, and sometimes they don't want to be informed immediately. They might come back again after maybe a couple of years. So we can't call them and say this is happening. This no, no, we don't.
Perfect. Does blood type of the donor matter? Are we given this information?
So yeah, well, you will be given this information, and you will have, but no, it doesn't matter, because you need to consider that it's the same thing if your child has a different blood group, because your partner has a different blood group, and the baby come with a different blood group. You will be given immunoglobulins at the time of the delivery normally. So it's the same principle. No, you don't need to match with the blood group.
Okay. Um, when a donor donates eggs and say 12 eggs are collected, are they split up in multiple batches which can be purchased? How do you decide which eggs to go in each batch?
We don't decide the eggs. We can divide. Yes, we do, and we divide by batch of 6 or 10 normally are the batches, but we can't select which one is. No, that doesn't work like that. Embryologists just split the numbers. We don't pick. we don't pick and choose. No. No. But we do divide the numbers, batches of 6 or batch of 10.
Perfect. Those are all the questions for today. Thank you very much, Dr. Vendola. And with that, it also brings us to the end of today's webinar on IVF with DonorX. Thank you very much, Dr. Vendola, for sharing such invaluable insights and expertise with us today. And a big thank you as well to our attendees for joining us and your thoughtful questions as well. We hope this session has been informative and helpful for you. If you have any further questions or if you would like more information, feel free to reach out to us through our website contacts page. And we look forward to seeing you for our future sessions as well. Thank you very much. Have a lovely
Thank
evening,
you.
everyone.
Thank you, Shifa.
Thank you.
Thank you.